So we're going to take what we learned about blood pressure and apply it to something called the baroreflex. With this video, we have these two primary outcomes. Remember that I have often said that physiology is all about a series of dominoes. Baroreflex is a perfect example of that, and hopefully you can see that as we go through this video. So the baroreceptor reflex, also known as the baroreflex, is ultimately how your body regulates blood pressure. Okay, and it does this by altering blood flow. Okay, we're going to talk a little bit more in the urinary system about how the kidneys regulate blood pressure, but it's an entirely different mechanism. Okay, there's also something called the chemoreflex that we're not going to talk about in this class. But the chemoreflex, just to at least let you know that it exists, is where blood pressure changes because we're trying to adjust for changes in oxygen or carbon dioxide in our bloodstream. So to start off, if you remember, physiology, all about feedback loops. This starts with some sort of receptor. We have baroreceptors. These are located in your aortic arch, so right outside your heart, as well as your carotid sinus. The reason we have these receptors in that location is because if there is an issue with blood pressure, with blood leaving your heart, there's going to be an issue with pressure everywhere. Let's just imagine that I had baroreceptors in my big toe. If there's an issue with blood pressure in my big toe, there could be issues everywhere, or it could just be something's going on with my big toe. Ultimately, these baroreceptors act kind of like balloons, which is why I've got that picture here. They get stretched out, and when they get stretched out, that's how they know pressure is high. So I've got this circle on this balloon here. Imagine what would happen to that circle as I increase the amount of pressure inside the balloon. It would stretch out and get bigger. And so these baroreceptors send signals like all receptors do via action potentials. When there's increased pressure, they stretch. And when they are stretched, they send more action potentials. When there's low pressure, they send out fewer action potentials. So when it comes to regulating blood pressure, as we talked about earlier, there's a few variables. So we've got heart rate. So this is the SA node firing rate. This is one of the first things we talked about with the cardiovascular system. This is regulated by both branches of the autonomic nervous system. Then we've got stroke volume. So this is just regulated, or what we're regulating here is how hard is the ventricle contracting. This is primarily regulated by the sympathetic nervous system. And then we've got total peripheral resistance. And if you recall, resistance is most affected by radius. And the things that can change the radius the easiest are arterioles. This is also a sympathetic nervous system, or a thing that's controlled by the sympathetic nervous system. But ultimately, each of these variables directly affects pressure. So let's go through an example. Let's say you change body position. So you go from supine, which just means you're lying down, to you're standing up. Well, what happens is your pressure will drop below normal because what's happening is gravity is having a greater effect on your blood. Okay, it's pulling blood down to your feet. This is why, in some cases, if you get up too quickly, you feel lightheaded. Happens to me every weekend when I watch football. I get off the couch to go eat something while there's a commercial, and I get lightheaded. Right? As a result, because pressure has reduced, the baroreceptors aren't as stretched out, and so they send out fewer action potentials. Brain now knows pressure is low, and so it wants to do something to get it back to normal. Again, negative feedback loop. It will do this, the brain will do this by affecting heart rate, stroke volume, and resistance. Remember, mean arterial pressure equals heart rate times stroke volume times total peripheral resistance. So we're going to go through each of these variables on one slide. So heart rate. So notice we've got a sympathetic nervous system and a parasympathetic. So the sympathetic nervous system, we increase that tone or that activity. That causes more norepinephrine release onto the SA node. And so that activates beta-adrenergic receptors. As a result, more sodium channels open, which increases the slope of the drift. The parasympathetic side, we decrease that activity. And so there's less acetylcholine being released, which means there's less activation of those muscarinic cholinergic receptors, which means there's less potassium channels open. And this also increases the slope of the drift phase of a cardiac pacemaker action potential. Heart rate increases. When we increase heart rate, we increase pressure. Let's do the same thing with stroke volume. Again, activity increases. This causes epinephrine to be released, and this time we're talking about epinephrine that's released onto the ventricle. We activate more beta-adrenergic receptors, but in this case on the ventricle, we open calcium channels, which means there is greater ventricular contractility. Remember, more calcium, more cross bridges, more force. Parasympathetic side, no real effect. So as a result, stroke volume increases, and if stroke volume increases, pressure increases. Last one, resistance. So in this case, the tone increases because it's always been increasing here. So there's increased epinephrine release as well as angiotensin II. Okay, we haven't really talked about angiotensin II, but I want to bring it in here. It does the same, it has the same effect on the arterioles that epinephrine does. Different receptors, but same effect. Okay, with epinephrine, it activates alpha adrenergic receptors. Angiotensin II activates angiotensin receptors. Okay, and this ultimately causes vasoconstriction. Okay, it does this by increasing calcium inside the smooth muscle. More calcium, more cross bridges. In this case, they're called latch bridges, but it's the same idea. Parasympathetic side, there's no effect. As a result, we have this vasoconstriction, which increases resistance, which increases pressure. So to summarize, pressure drops, the baroreceptors fire at a lower rate, brain senses this, and so it responds by increasing sympathetic activity and decreasing parasympathetic activity. Ultimately, this will increase all three of these variables: heart rate, stroke volume, and resistance. Pressure increases back to normal. One of the last things I want to talk about is tie this into systolic and diastolic blood pressure. Remember, systolic blood pressure is caused by the blood that actually leaves the ventricle and enters into the aorta and the rest of the arteries. Heart rate and stroke volume directly impact that because those two variables impact or affect how much blood leaves the ventricle. Diastolic blood pressure is caused by the recoil of the arteries. So TPR affects the recoil of the arteries. If you've got vasoconstriction, those arterioles aren't going to want to, and the arteries aren't really going to want to stretch out, and so the recoil is going to be stronger. One more thing that we want to talk about that affects blood pressure is blood volume. So I've mentioned this in class. We've got pictures of water balloons here. If I give you a water balloon and I say increase the pressure, there are two things you can do. One is you can squeeze it. The other thing you can do is put more water in it. Okay? If we increase the amount of blood in the circulatory system, we're going to increase pressure. And so we can mess with blood volume to maintain or alter pressure. And this is really where the urinary system and the kidneys come into play. This is something that takes a little bit longer. So we've got a couple of hormones that we're going to end with here. So if we want to increase blood volume, we can release angiotensin II. Now, angiotensin II indirectly increases blood volume. What I mean by that is that it takes a couple of steps for this to happen. Okay, angiotensin II will actually cause hormones or stimulate the release of hormones or the activation of hormones that will cause salt to be retained. Okay, and if we hold on to salt, we hold on to water. And if we hold on to water, basically we're pulling fluid out of the extracellular fluid, or the interstitial fluid is a better place to say. And that goes back into our bloodstream, and so we increase our blood volume. Aldosterone also does this indirectly. Aldosterone is actually stimulated by angiotensin II, and the job of aldosterone is to pull sodium out of the fluid that would become urine and ultimately bring it back into the bloodstream. If we bring salt back into the bloodstream, we're going to hold on to water, because wherever there is salt, there is water. ADH, or vasopressin, which we've mentioned earlier, this is the hormone that directly affects blood volume, because it actually opens water channels so that water can go from the fluid, the filtrate, which will become urine, and gets it eventually back into the bloodstream. We have something called ANP, and ANP essentially does the opposite of these hormones. It causes us to get rid of sodium, and it causes us to get rid of water. Okay, and so if we've got high blood pressure, we'll release ANP to get rid of some of that water. So with that, here are the two questions, or two things that I hope you can do. Can you explain how the baroreflex works? And can you identify hormones involved with maintaining pressure and volume?